Welcome back to our interventional versus medical management debates. I'm joined for our first debate with Dr. Richard Klucznik and Dr. Rajan Gadhia. Dr. Klucznik is the medical director of our interventional neurosurgery program, and he will be taking the position that straight to thrombectomy is superior for patients with large vessel occlusion. And Dr. Gadhia is the system director of acute neurology for Houston Methodist and will be taking the position that bridging thrombolysis is superior than compared to direct to thrombectomy. So I know this will be a provocative debate, and I know that Dr. Klucznik's videos often get some of the best reviews, so you're in for a treat. We'll let you go.
Well, good afternoon. Thank you for inviting me, and I couldn't do this without my partner, Dr. Diaz, down at the bottom there. The two of us are a team together. When we think about stroke, we always say time is brain and time is of the essence. So our job is to stop the inevitable from happening. We have to step in and get the clot out and save the day. And this is our goal. Our goal is to get, this is just pictures of all our trophy cases, if you would, of our clots that we managed to get out. First, I'll start off with basically there hasn't been many studies done, but there are two randomized studies that have been recently published just on this fact alone. The first is called the SKIP trial, basically you're skipping TPA and going straight into mechanical thrombectomy. And that trial basically showed that basically they did 204 patients. And the primary endpoint was defined as, the modified Rankin score. But what they really found was that the non-inferiority margin was not met. In other words, it was equal. So it's not really truly a great study, but at least it didn't show any damage to direct thrombectomy. The second one is this is a long title, but it's basically TPA with mechanical thrombectomy versus mechanical thrombectomy. If you ever wonder how they get the name, it's called the DEFT trial. And there it is, direct endovascular thrombectomy versus combined IVT and endovascular thrombectomy for patients with acute large vessel occlusion and anterior circulation. That's a mouthful, just for that study. And they were multi-center, and this was done in China. The SKIP trial was done in Japan. So they had 33 different stroke centers in China, and they randomized a total of 116 patients to endovascular thrombectomy alone and 118 to both. And the primary endpoint was the patients achieving functional independence. And the findings of that trial is that the proportion who received functional independence was 54.3 in the endovascular treatment alone versus 46.6 in the both group. And among the patients with large vessel occlusions, endovascular treatment alone met specified statistical threshold for non-inferiority. They weren't trying to prove that it's better. They're just trying in this study to prove non-inferiority. That's not worse than IVTPA and mechanical thrombectomy. And the trial was going so well that when they did the initial investigation as the Data Safety Monitoring Board, it was going so good that they actually stopped the trial. And after they did 194 patients because the data was so strong. And they compared it to other studies too, with the Hermes study, and again, that's a nice name, highly effective reperfusion using multiple endovascular devices, Hermes. And they also compared it with direct MT, which is, it's not really mechanical thrombectomy. They were studying how to transfer patients directly to an acute level 1 stroke center. So this trial is actually better than those two trials for mechanical thrombectomy. And then when you compare the two trials, the rate of intracranial hemorrhage was higher among the patients in the combined group, and I'll get to some of that too, even though patients, the SKIP trial, didn't even receive the full dose of TPA. And this sounds like a racist statement, but this is a reviewer of these articles said, the SKIP trials only included Asian patients, so it sounds like a little bit of racism going on, but it's true. They were done on the Japanese and Asian and Chinese patients, but they have a large proportion of atherosclerotic disease in China. And this paper, we know several of these people also looked at this, and it's quite interesting. Someone found this is the harm of IV TPA, and I'm going to highlight some of those things. By giving TPA, you may have puncture, site hematoma, systemic bleeding, IVTPA-related coagulopathy, the increased rate of intracranial hemorrhage is higher, and blood-brain barrier breakdown. So it may be a little bit higher. And IVTPA safety, it increases the risk of intracranial hemorrhage because you can have early infarct signs in CT. There are small microbleeds. The older patients, high glucose, so it can disrupt the blood-brain barrier. And continue down the list of what can happen when you give IV TPA. Some of the things is distal thrombus migration. You actually take say an M1 and you convert it to an M2 and M3, and then we can't do it anymore. We can't go after those anymore. And other things is delay. You're instituting the IV TPA, and that's a delay into getting into the mechanical thrombectomy, and there's allergic reactions and cost. So clot fragility. Clot, you can convert a treatable LVO, nice big M1 or proximal M2 into a distal one. It may not be able to get it. And this is coming, a slide that I show is, I'm not sure if you can see the arrow, there's a M2 segment that's gone. And when we do the mechanical thrombectomy, you see that M2 segment is actually a trifurcation. And you didn't know that beforehand. You can easily poke through that because you don't know. You're suspecting it's a straight blood vessel. Also, when you're giving IV TPA, it limits the possibility of putting a stent or something that you may need, or ongoing clot formation. Here's an old case that I had of an M1 occlusion, their underlying stenosis, and at that point, this is an older case, the patient did not get TPA, and we did put a stent in at that time, and he did well, and very well. And this is a more recent case where there's a carotid stenosis, and there's actually clot sitting down at that carotid, and there's an M1 occlusion up above. So, well, I was not able to put a stent in, but I did angioplasty, and I was able to get the catheter by and go up and get the clot out too. Cost is in money and time. Cost is higher, and there's also delay. When you think about delay, this is our group. This is our team. You call us, we're ready to go. We are coming in, and we're coming in to do something. We're not coming in to sit around and wait. It's delay in time. So all of a sudden we come in and we jump into the lab, and all of a sudden there's a delay. TPA is this, right? Emerson, you got to get the IV going. You got the anesthesiologist is charting. So we're delayed, and we're getting better at this.
Today, Don.
We're getting better.
They're really biting today, Don.
It's all about the lure.
Dude? And I think it's about time.
Oh, they're really biting today, Zorak. Yeah, it's all about the lure.
Refreshingly smooth Bud Light.
It's all about the lure. We have many more devices that we ever had before, and there's still. I just talked to Penumbra yesterday, and some newer devices are coming. There's new suction devices that are coming. This is the Zoom catheter. That's basically applies suction to the clot, and this is a whole new line of different catheters that may work better than what we have. So, yes, we do suck. We suck clot. So here's an M1 occlusion. This is the Zoom 71. It's a new catheter. So I get the M1 open, but now there's the clot in the M2s. And this new catheter was able to go up there easily and get clot out first of the inferior division. And then the second one, I go up and get the posterior division. There's a white clot that we pulled out that's stuck on the tip of this catheter. And there's the second M2, and we were able to get that open. And there's the clot also on that one too. And then we're getting better with our anatomy. This is a patient who had, as you can see, a graft. There's a big stent there. They had transposition, the carotids. And with the new catheters, we're able to get up there. And this patient is in trouble because he's living off that one carotid. And with the 3D, you can see there's an M2 segment that's out. And with our newer devices and able to get there, there's the M2 that's out. And we're able to get there and open that up. So much of the stroke reperfusion is derived from the cardiac guidelines as well, too. The PCI recommended just direct reperfusion, and their meta-analysis said that PCI is superior to thrombolysis. And again, of all the trials that they do, it's overall short-term death. So sometimes we may follow the cardiac literature. So in summary, mechanical thrombectomy may be superior to both, but in my recommendation, if a patient comes to the main ER here where you don't have to transfer, it's just maybe better to come straight to angio rather than doing anything else. Thank you.
Thank you, Dr. Klucznik. We'll hear from Dr. Gadhia, and then we'll have some cases that illustrate this complexity. I have to say, I'm struck with just every case is different when you're an interventionalist. There's no N of 100, it's just that N of 1, and everyone is just a little bit unique.
Yes. Everybody's different, and everybody's a different challenge.
Right.
That's why we have different devices in a way too, because we don't just use a standard device. I look at the CTA before I start. I look at the CTA of the neck and the head, and I'm deciding which device I need to get through here, and then which device I may need to go upstream. So yeah, it's a decision-making process.
Well, Dr. Gadhia, take it away.
All right, it's hard to follow those footsteps, but I'm going to walk us through a little bit of a history lesson, hopefully, on where we started with acute stroke therapy. So just to start, no relevant financial relationships, and we'll start off by talking a little bit through a timeline of the acute stroke studies and the data for intravenous thrombolysis. We'll talk about the stroke systems of care in the 2020s and some of the clinical trials in addition to the studies that Dr. Klucznik just mentioned. So for those of you that have seen any talk that I've given, you know that I love timelines because I think it shows a fairly great overview of what we've done in acute stroke over the last 25 to 30 years. And we date back to 1995 with the original NINS TPA study, the first really landmark study where we had a therapy for acute stroke patients. It wasn't just let's bring the patient in, let's see how they do, and we'll see what their outcomes are at 90 days. We actually had an intervention to provide for these patients, and it was a very effective intervention. And you can see there on the timeline that it was about 13 years before our European colleagues published the ECAS-3 study showing the benefit of pushing the time window out from 3 hours out to 4.5 hours. It wasn't until a couple years later that we started to encroach the envelope, similar to our cardiology colleagues, of looking at intervention and performing thrombectomy in patients. And I always say, if you've got the right inclusion-exclusion criteria, the right endpoints, you can design a positive clinical trial if you've got a strong therapy. And it's clear that endovascular therapy is a strong therapy. In 2015 to 2016, we had a number of landmark studies showing the benefit of endovascular thrombectomy, so much so that it made it into our guidelines. We pushed the envelope a little further, out to 24 hours, and we had an extended window protocol for those that had a mismatch. And we've come full circle now in the late 2010s of pushing the window for intravenous thrombolysis. And I'll show you what the timeline looks like with bridging therapy. So here's what triage really looked like about 10 years ago, really even 6 years ago. On the left, a patient came in. If they were a TPA candidate, they got TPA. If they weren't, they were admitted to the floor or to the ICU. And you can see there on the right that this is what the reality of what everyday triage looks like for the vascular neurologist or the neurologist on call. And it's always in draft format because we are always learning and we're always leading to try to get the patients the best and most evidence-based therapy. So Dr. Klucznik and a number of others have already alluded to the functional outcome measure, which is modified Rankin scale score. It's a scoring tool from 0 to 6. The higher the number, the worse the disability, 6 representing death. And here's a graphical representation of every one of those studies that was on the original timeline picture, showing a leftward shift towards the therapies and showing the benefit of TPA there on the left and the right, and in the middle there showing the powerful benefit of mechanical thrombectomy. And this is reflected in the acute stroke guidelines. But one thing that has remained stagnant and remained sort of a mantra among acute stroke care is the level 1 evidence for thrombolysis. The level 1A evidence for giving TPA to a patient within 3 hours of last known well and that otherwise has disabling deficits, and the level 1B evidence to push it further for 3 to 4.5 hours. Now, the question has come up as to what is the appropriate thrombolytic agent in a patient that has a large vessel occlusion. And I think here we've got some room to grow. There was a head-to-head study looking at tenecteplase and alteplase in patients who came in with large vessel occlusions and were candidates for mechanical thrombectomy. And you can see there that looking at 90-day modified Rankin scale scores, that there was a leftward shift towards benefit of tenecteplase in these patients. And tenecteplase, is a faster infusion. It still has not received, the clear-cut level 1 indication, and it's not been the standard across most sites. But I think that is an area that we're moving towards in stroke care. You can see there that the baseline 24-hour and 72-hour NIH stroke scales really weren't different between the two therapies, however. And I won't go through the catheters because Dr. Klucznik has done a great job going through all the different devices that they've got for performing these thrombectomies, some so much so that they can go to the M2s and even the M3s. And so some of the arguments and points made of clot migration may not be pertain to what stroke care looks like with the newer catheters. And so here's a review article by Dr. Gralla and his group, the same investigators for the Swift Direct study. And I think Dr. Klucznik did allude to a couple of these points, but what are some of the benefits of bridging thrombolysis? Well, TPA can be started earlier than mechanical thrombectomy. In some patients, it can lyse completely a proximal occlusion before the thrombectomy even starts. We know that the more distal the occlusion, the higher the likelihood, a number needed to treat of just 6 for an M2 occlusion, whereas the proximal occlusion is probably less likely that the thrombolysis alone is going to take care of that patient. It allows for potential recanalization in patients with failed mechanical thrombectomies. So there could be delays or technical difficulties in access to get to the lesion. And for those patients, at least you've got a lytic agent on board to try to lyse the clot. It allows for recanalization of distal occlusions after thrombectomy. So there are microthrombi that may be projected further distally, some in vessels, in the smaller vessels that we can't even really image, even with a cerebral angiogram, where a TPA can help to recanalize those small areas. And we know that the higher the chances for TICI-3 reperfusion, the better the functional outcomes. And so just to summarize sort of those points that, early reperfusion, especially if it's a short segment thrombus or there's residual flow, certainly thrombus softening to make the thrombectomy, potentially more successful. Chances of reperfusion in those patients where access is an issue and getting up to the thrombus is an issue. And then certainly reperfusion post-thrombectomy. And so let's move further down in the data. This is a prospective study that was published by our colleagues at Johns Hopkins, looking similarly at the outcomes of bridging thrombolysis versus directed thrombectomy in the drip and ship model, as well as patients presenting to the thrombectomy capable site. And once again, you see there these graphical representations of a leftward shift of patients receiving bridging thrombolysis, both in discharge modified Rankin scale score as well as the 90-day modified Rankin scale score. So the conclusions that those authors had were those patients that were undergoing mechanical thrombectomy for large vessel occlusion, TPA as a bridging therapy did not delay treatment times or result in increased clot migration. We've gotten extremely efficient in ensuring that TPA and administration of these medications are not going to delay starts of thrombectomy procedures. In fact, we will give the bolus oftentimes and send a patient down to the endovascular suite while they're continuing to infuse the rest of the intravenous infusion. Certainly no increased risk of clot migration or difficulty with extraction or intracranial hemorrhage that was seen significantly. And so let's talk about the randomized controlled studies. We heard a little bit about the SKIP study as well as the DVT study from the Asian countries. And certainly there is intracranial atherosclerosis. I think the disease burden may be just a little bit different. The standard of alteplase dosing may be variable between what we practice there and what we practice here, which may lead to some of the discrepancies and the differences that we found in the different clinical trials. But RACECAT was a multi-center superiority cluster randomized cohort with a blinded endpoint assessment. And the objective was really to see for those patients who had a high suspicion of large vessel occlusion out in the field based on scores out in the field, whether those patients, when transferred directly to a thrombectomy capable center compared with a standard process of going to the closest primary stroke center, whether they had a more favorable outcome. And to really not my disbelief, the RaceCat trial did not show any superiority of sending a patient directly to the mothership or the comprehensive stroke center when compared to the drip and ship model. It really set the stage for addressing how are we going to look at future stroke systems of care, because I think this is something that not only our community here in Houston, but many regions around the country and really around the world are looking at what is the best way to address and direct patients with acute stroke presentations. And here's our evolution of our stroke systems of care. I use this oftentimes in our telestroke network, but really what we've done is we've seen these primary stroke centers grow into thrombectomy capable centers and comprehensive stroke centers. We've also seen a number of acute stroke ready hospitals come up. So we've got excellent centers that can offer the most powerful treatment that we've got for majority of stroke patients, which is intravenous thrombolysis. And why should we give every minute of 2 million neurons a chance to not survive if it's going to lead to further delays in getting to the comprehensive or thrombectomy capable center? And so here's something from our own Southeast Texas Regional Advisory Council, which looked at exactly this. How are we going to address this if we've got a field score that predicts a high pre-test probability of a large vessel occlusion patient? Should we take that patient to the closest stroke center where we can give TPA or TNK, or should we take them straight to a thrombectomy capable center? And it turns out that at least within our algorithm, and this is an ever-changing thing, that if there's not going to be an increase in 15-minute delay, that we can consider sending those patients directly to a thrombectomy capable center. But nowhere in the data does it mention, or nowhere in the pathways does it mention that we are going to bypass lytics. Another randomized controlled clinical trial, Mr. Clean No IV. It was an open label, multi-center randomized trial, European population closer to the American population, who presented directly to a hospital capable of providing mechanical thrombectomy. So we're not even talking about patients presenting to an outside primary stroke center and transferring, but a patient actually presenting to a thrombectomy site. And patients were randomized at a 1-to-1 ratio for thrombectomy alone or bridging thrombolysis. And in this study, they found that it was direct to mechanical thrombectomy was neither superior nor non-inferior to bridging thrombolysis with regards to the modified Rankin scale score at 90 days. And so the incidence of symptomatic intracerebral hemorrhage was really no different between the groups. And yet another final randomized controlled clinical trial. This one actually I haven't even seen the paper for, but these results were presented in September of 2021, so really hot off the press just a couple months ago. And I'll show you sort of that press release. But the objective of this study was to look at whether patients who had an acute ischemic stroke with a large vessel occlusion in the anterior circulation, would they have non-inferior functional outcomes at 90 days if they went direct to thrombectomy when compared to those patients who got bridging thrombolysis. They also look at secondary objectives, including all-cause mortality as well as dependency with quality of life measures. And really, they just wanted more information and more conclusive information as to the safety and efficacy of direct mechanical thrombectomy compared to bridging thrombolysis. They plan to enroll a little over 400 patients. They had a treatment-blinded person doing the modified Rankin scale scores. A good outcome was considered an MRS of 0 to 2. Anything 3 and above was considered an unfavorable outcome. And there's the press release hot off the press in September of 2021 from Dr. Gralla himself as well as his partners, where the Swift Direct study failed to demonstrate non-inferiority to bridging thrombolysis. And I think we've got now a number of clinical trials that are applicable to our own patient population that tell us that TPA or TNK or whatever lytic agent comes across, that will remain the standard of care. Thank you. And these are my references.
Thank you, Dr. Gadhia. We'll bring up some cases now, and as we do, I'm going to introduce the next two discussants. My colleague, Dr. Vivek Misra, will join us. He's a vascular neurologist at Houston Methodist Hospital and has had a particular interest in acute stroke management, including mobile stroke units and their application to our patient care. And as Dr. Klucznik alluded, our colleague, Dr. Orlando Diaz, an interventional neuroradiologist whose expertise is internationally renowned and known throughout all his colleagues here in Houston and beyond for the many patients he's treated for stroke and other neurovascular disorders. So here are the cases. You, the audience, will hear from Dr. Diaz and Dr. Misra and then vote. Case 1 is a 70-year-old man with a history of atrial fibrillation, not on anticoagulation, who presents directly to your emergency room after the family witnessed an acute aphasia and right hemiplegia. Blood pressure is high, 175 or 105. Interestingly, very close to an important cutoff there. The exam, the patient's eyes are open. The cranial nerves show a left gaze and a right droop. The patient's left side is 5 out of 5, but the right side is 0 out of 5 in the upper and 2 out of 5 in the lower, coming out to an NIH of 16. And here is a very clear CTA. So we won't enter your poll response now, but we'll come back to that case, and you will. Here's the second case. The second case is a 42-year-old man with a history of a bicuspid aortic valve not repaired, not on anticoagulation, who presents with acute vision loss and dysconjugate gaze. His blood pressure is 155 over 95. He's lethargic, his speech is slow and dysarthric, his cranial nerves show absent visual fields, a bilateral third nerve palsy. On the motor on the left and right is 2 out of 5. His NIH is high at 20. He is called in with this exam from EMS, who performs an initial non-contrast CT and pre-alerts your center that the patient is coming from a rural location and has 45 minutes before they arrive. And this is the non-contrast CT, and many of you will recognize the yellow arrow sign, which indicates that the patient has something going on right there, and that something is a basilar tip occlusion. So with those cases, I'll turn it back over to my colleagues, Dr. Misra and Dr. Diaz, and I think that Dr. Diaz, you have the floor to discuss the cases.
So can we see the first one, please?
Sure, I'll go back to that.
So this is the main difference between these two cases is the way that this location they presented. The first one is an N1 segment occlusion, and it's in our ER. If this is an ER, we're ready to do the mechanical thrombectomy in less than 30 minutes. So we're there. So given TPA or not given TPA, according to what has been clearly discussed by Dr. Klucznik and the rest of the team, is meaning that it's not going to change a lot because we're there, and then if we don't have to give any ITPA, if the patient is transferred immediately to the angio room, we can go and do a mechanical thrombectomy and very quickly to get the clot out. So in this particular case, I don't think that giving TPA intravenously is going to get anything better to the patient if we are faster to do the mechanical thrombectomy. So in this particular case, my opinion is transferred to the room, to the interventional neuroradiology room, and we, with all the tools we have, we can do a mechanical thrombectomy.
And Dr. Diaz, do you want to give your opinion on the second case?
Second case is a little bit different. The second case is 45 minutes away, and it's a basilar tip. The intravenous TPA in a basilar tip can reopen that basilar according to the studies in 4% of the cases. So we know that given intravenous TPA, a difference to the first case that is between 21 and 30% in the N1 segment, TPA, let's talk about the first case. When we give a TPA, we have the option, the possibility to open the N1 segment between 21% and 30%. And the basilar occlusion, TPA is going to work only on 4%. Why? Because it's longer than 8 millimeters. So in this particular case that the patient is far away, it is 45 minutes away, I don't think that it's going to hurt given TPA. So because it's eventually have a little bit of option, and also we have the advantage of maybe to destroy the little clot going to the distal PCAs from the basilar occlusion. So this particular, the second case, taking into account the high morbidity and mortality of the basilar occlusion, the patient is 45 minutes away from the main hospital, it's better to give TPA.
All right. Making your job a little easier, Dr. Misra. Let's go back to the first one. Do you want to give your opinion on the M1 occlusion?
So let me talk about some concerns which our interventional colleagues have. Is TPA might increase the bleeding risk, might delay the groin puncture, might delay thrombectomy. So the opinion I have, and this is now coming from the experience of these 3 randomized clinical trials, we have several hundreds of patients, that TPA does not delay thrombectomy. TPA does not increase the bleeding risk. What TPA can do is, if TPA were to open the MCA, now it opens the MCA, we know in mainly, I would say 30-35% patients, But if it opens the MCA, it can open the MCA much faster than anything ever can. And that's something we have seen in our ED as well. We use TPA. Almost 1/3 patient, they go to the angio suite and the MCA is open, and they do beautifully well, fantastic. So what about those where TPA is not able to open the artery? So we know that TPA will not endanger the patient. There won't be higher risk of bleeding. There is only going to be an upside, which is faster reperfusion. There is a concern raised about the clot migrating distally, but this is where TPA works beautifully. So if the clots migrate distally, that is best lies by TPA. So I think TPA is a win-win situation, whether the patient is in our own ED or the patient is outside. TPA has also been shown to reduce the clot burden. And there are studies where, they've also shown that the number of passes you need to, be able to open, if the clot is soft, you can easily extract it much easier. So when we look at some practical things, and those practical things are real-life situations completely outside of clinical trials. So for example, the patient needs to be intubated. If you've not treated this patient with TPA, you are further delaying reperfusion. Maybe the clot will open, maybe it will not, but it will still have worked on the clot. A lot of our patients, they have obstructive sleep apnea. They have all these stroke risk factors which can also affect the cardiovascular system. They need intubation, or they may worsen on the way to the angio suite and they need intubation. That again delays their reperfusion. Apart from this, a lot of these patients do have peripheral vascular disease, something I have seen in my clinical experience for 15 years. It takes some time to get groin access, get all the way up to the clot, regardless of whatever devices we have. So TPA is a win-win situation. It can only help improve the chances. It can only help the neurointerventions do a much better job than without using TPA. And who knows, in 1 out of 3 patients, it can still open the MCA. And by the time we get up north, the clot is gone, the artery is open. So that's my take on this based on the experience of so many clinical trialists treating these patients for 15 years. And obviously now we have clinical trials to support all these things. So obviously now we go to the next one where this patient has a distal basilar occlusion, which is really hard to lyse, as Dr. Diaz pointed out. There is again no downside to TPA in this situation. The mid-basilar clots, they are more easier to lyse with TPA, I agree. The distal basilar clots, they can also be triangular, they can also be going into the PCA, so it's a much harder fix to fix with TPA alone. But this patient is far away. We know from the basic study is that patients, whether or not they were treated with TPA alone or treated with TPA plus thrombectomy, they didn't have much differences in outcomes. This is from randomized clinical trials done in a patient population similar to the United States. They were done in Europe. But I would never want a patient with basilar occlusion not get all treatments that we need for them to stay alive and stay well. So this patient obviously is far away. And if we were to treat this patient, and we know the Houston weather, we may not be able to fly them. They may need to come through ground transport, may not be able to get to us in time. If this patient were to be somewhere in the Midwest, somewhere in the Middle East, and we know how the weather is in more than half of the country, they can never even get to a comprehensive stroke center, at least if they fly or they were to go through ground transport. So my feeling is TPA in this situation will still be a win-win thing. A lot of times when you have to go through to get to the basilar, you have to go through the vertebral arteries, and there can be a lot of disease in the vertebral arteries in patients who have vasculopathy, atherosclerosis. So it's not like you open the head, you get to the basilar, you have to really navigate through a lot of tortuous arteries. All of these can take time. The anatomy can be so different. One of the words can be codominant, or one can be non-dominant, the other can be dominant, but still have a lot of atherosclerosis. There can be a lot of tortuosity to get the guide catheter up to where it has to be. So I think in any situation, whether the patient comes to us directly to the comprehensive stroke center and Dr. Diaz is ready to go, or the patient comes to us, we can approach them through telemedicine, but we can expose the clot much earlier to TPA than we used to do before. There was a saying, and Dr. Klucznik mentioned that we have become better with catheters and with more endovascular interventional experience. I would say that we have become far better in 25 years of thrombolysis with the stroke system of care, with telemedicine, and now with mobile stroke units. We can dissolve the clot with TPA within 5 minutes of the onset of symptoms, we can get to the patient, we can start these treatments, and then Dr. Diaz and Dr. Klucznik will be waiting in the angio suite. We'll have flown the patient directly, but we'll still have exposed the clot to TPA. We can still do much, much better for patients with this bridging approach than we would otherwise do with not exposing the clot to TPA. So I think TPA as a bridging treatment is a win-win situation. There is no downside to it, absolutely no downside to it.
Well, I want to give Dr. Diaz the last word here, and I want to come back to this basilar tip case, where let's assume that this patient does not have access to the TPA in those 45 minutes, that the first time they'll have chance to get that TPA is at arrival in our emergency room. Would that change your perspective? Once they arrive, should they get TPA and then come to you, or would they go straight to thrombectomy, in your opinion?
From the interventional standpoint, getting a clot from the basilar is easier than MCA because the anatomy. And this is what we can do, aspiration by itself, where the aspiration is even better than in other place because it's a straight segment. So I don't think that it's going to help a lot to give TPA, but taking into account the mortality rate that we have, if the patient is coming here, when I agree with that a TPA is not going to hurt, and it's a basilar, the mortality is more than 70-80% on these cases. So the more we do for the patient, the better. So I think that is a good idea to give TPA even when the patient is in the ER going to the interventional suite.
All right. Well, it's time to get everyone on record here. Let's see. Let me go back. Okay, so again, to remind everyone, the first case, and we're going to open the poll here in just a moment, is the 70-year-old patient with AFib, not on anticoagulation, high borderline blood pressure, high NIH stroke scale, and a clear M1. So please vote. And if I think the poll everywhere should be coming up. And if you don't see that poll yet, just bear with us a moment while we get the poll up. While we're waiting for that, I'll just say that it is interesting when we think about the level 1A evidence, it really is the anterior circulation. So I intentionally put this curveball in on the second case of a posterior circulation. In a state where we're somewhat short of evidence, where we don't have as much clinical trial, do you feel differently in that circumstance of a posterior circulation, Dr. Misra?
I would still treat a basilar occlusion the same way as I would the anterior circulation. I don't think the amount of mortality and morbidity with basilar occlusion that is, we would never want to, have a patient not get TPA as well as not get thrombectomy. I think they should get every chance they have to, I would say, stay alive and stay as well as they can.
Yeah, and that it sounds like everyone is on the same page. So we'll leave it looks like we're getting quite a few responses here through the poll, and I'm looking at the numbers, and right now maybe is some people are choosing direct, some people are choosing bridging, some people are trying to split the baby and give IV TPA en route using a stroke ambulance, which makes a lot of sense. Some people are even raising the question, what if the patient is outside the typical 4.5-hour window? In that case, would that alter your opinion in non-standard TPA cases?
So, I mean, if they're outside the 4.5-hour window, there's no doubt they should go straight to thrombectomy. And I do think as the system of care evolves, we are quite likely to see tenecteplase in that role, and there's a lot of hearsay about TNK being effective up to 6 hours as well.
Yeah.
But I think when it comes to the current available trial, I think beyond 4.5 hours, they go straight to thrombectomy because we don't have evidence in that way.
I agree 100%, yes.
Well, that we'll close the poll on that one. It looks like we got a good debate there. And the second case was the 42-year-old with the basilar tip, and we'll now turn that over to the poll. This patient coming from maybe a rural location with the inability to take a helicopter is coming by ground for 45 minutes. So I think that when we do face a disabling disease that is so daunting, one does wonder, even a small difference in time being potentially magnified, and at what point does the delay become enough that you want to shorten that? And does that influence you, Dr. Diaz, if you see that the patient has already been delayed for whatever circumstances, whether it was bad weather or far location? Dr. Klucznik said your team is ready. You land on the shore ready to go, and then have to wait, with a TPA bolus, some kind of infusion. Does that influence your feeling about whether the patient should have had it in the first place?
I think that if the patient is coming and the infusion is going, it's not going to stop us to do the puncture, because we're doing now with a micropuncture set and with the ultrasound. I don't think that there is a high risk. So I think that TPA should be. I wouldn't change my approach.
Great. Well, I think our poll has now had its minute to be open. We'll try to get the numbers computed there. I'm watching the answers kind of scroll in, but not seeing a numerical one way or the other. So for now, we'll call it a draw. It was an excellent debate, and give a few minutes to switch over for our next debate. So thank you, Dr. Misra. Thank you, Dr. Diaz.